Great, thank you. So I thought I'd come here in my spare time, right? So the nice thing, when you hear all that is that scleroderma has truly been my first love. And over the time that I've been doing research in this area, both the interest is growing and certainly the hope is increasing because we have more and more treatment options out there compared to what we used to have. So these are my disclosures, or at least some of them that might be related somehow to this event. So I thought that I would be fairly clinical. So it's interesting that you're having, in a way, a physician answer the questions that we probably don't answer very well in clinic, because in the clinic setting, we try to say, okay, do you need a prescription renewal? And, what about this and that? But we don't always answer perhaps maybe the more patient-centered questions. So I don't have all the answers, but let's try to explore answers to questions of why am I so tired? Why do I have pain? And including why do my fingers hurt? Why is my function so poor? Why am I so itchy? Why am I short of breath? How can I feel better with my acid reflux and my other GI complaints, like feeling full early? What about my sore joints? And so that way I think it might complement the lecture you just had on the update and what's been going on. And as all of you are aware, this is a multifactorial disease, and I'm going to talk about some of these areas, but certainly not all of them. And any chronic disease can affect these areas, some more than others, some less than others. So fatigue and scleroderma. So why am I so tired? I mean, the general population probably has a fatigue score that's not 0 on average on a score of 0 to 10. But fatigue and scleroderma is really very multifactorial potentially. So sometimes we don't have an answer, but when people come in and rate their fatigue as being very high or their energy overall as being very low, we think of, okay, you could have low blood. So you could be losing blood from your GI tract, your erosions or irritation of your swallowing tube in the esophagus. You could have telangiectasia, little dilated blood vessels like you might have on your face, in your GI tract that then bleed. They can bleed, and you can have low blood from iron deficiency. But you can also have anemia, chronic disease. So when there's an inflammation state that's ongoing, sometimes your bone marrow is on partial strike and says, I'm going to have low blood, I'm going to have anemia because of that. You can also have fatigue from pain and poor sleep. Certainly depression is not rare in a chronic disease condition where there's pain and suffering and change in body image, loss of job, loss of well-being, all those reasons. And then also just to do things, there's more potential work when your hands don't work right. It's a bigger deal to try to get supper ready. It's a bigger deal to get dressed and get out the door. And if you're short of breath or deconditioned because of your disease, it's more work on your body to do the things you have to do. So all those things can contribute to fatigue. So in the clinic setting, when you say, why am I so tired? I go, usually, I don't know. But then I try to get to the bottom of it and say, some of these things I can help. So I can see if you have low blood and figure out why and work on that. Some of the things are very multifactorial and harder to address. And so we do have tools to address quality of life, and we do in our clinic at every patient, every visit, visual analog scale. So overall, how would you rate your energy? How would you rate your sleep? How would you rate your overall health? There's more kind of research ones like the SF-36. We wouldn't do that in a normal clinic setting, but we do in our registry annually. And then how's your function? Because if your function's quite impaired, I wouldn't be surprised that you'd be fatigued because it takes so much more work. So a health assessment questionnaire. And a lot of hand function and what to do there, I'll bring up a bit later in the talk, but our next excellent keynote speaker is going to talk about that. So we have published on sort of how much change does it take for you to feel better or worse. So that's called the minimal important difference. Because if you don't feel so well and I can't make you 100% better, can we make you a bit better that to you is clinically relevant? So in this sample, we had over 100 scleroderma patients that were seen for 2 visits in a row over a year. And the mean pain, just to know, on 0 to 100 was 40. Fatigue was almost 50. The mean sleep problem on 0 to 100 was 40, and global assessment of well-being, 100 being the best, was also 40. So I think it gives you an idea that there are an awful lot of symptoms in just our regular patients coming to a regular follow-up. They weren't calling for an emergency. So fatigue, pain, sleep problems, and functional impairment and overall global health as not being rated high is extremely common in scleroderma. And this isn't for you to understand the stats or anything like that, but what's important to know is that mostly over time, people are the same. This is over time, meaning just within about 7 months of follow-up, from 0 to 12 months of follow-up. But over time, most people are about the same. But I think what's important is that you're probably optimists, because in general, it takes less for you to feel better and more for you to feel worse. And that's actually, we found that in rheumatoid arthritis and in lupus as well. So in general, you can feel a bit better if something changes in the state of health, but you need a larger magnitude to feel worse. But I guess if you feel pretty bad, a larger magnitude, your state of health might not be much different. So we said, does it take more change to feel better than to feel worse? And if you look at the plus signs for your function health assessment questionnaire, you only needed a bit to feel better and a lot to feel worse. And for pain, you needed, and fatigue and sleep and global health, again, on some of these, you needed a bit more to feel better, but not that much to feel worse if you're already sort of on the high end of the spectrum. So if we shift gears and finish this area, you're fatigued or tired for multiple reasons, and some of these reasons are treatable and we can address them, and some of them are very intertwined, that it's not usually one thing, it's multifactorial. Pain in scleroderma, however, was not really talked about very much until probably the last 5 years, whereas pain in rheumatoid arthritis was a given. Swollen, inflamed joints, damaged joints, pain was really well talked about. So in scleroderma, we were a bit behind on understanding this. So pain, first of all, is common. The mean pain score, I said, is like 40 out of 100. So that means lots of people have pain. It's under-recognized. It can be from many sources: joints, flexion contractures, skin, ulcers, Raynaud's, GI tract. Sometimes your lungs even hurt if you have interstitial lung disease. Not always, but sometimes even they're painful. So it is often multiple different reasons. So if people tell me their pain is high, I say, well, why? What is it that bothers you most? Okay, if I can't address that, what's the next thing? And I usually try to find something we can address to improve the quality of life when someone's coming in. So as a subset of pain, people do ask, why do my fingers hurt? So when you're asking me that, or when you're thinking about it, it's again very multifactorial. Raynaud's can be quite painful, and to be quite honest, in a lot of studies, Raynaud's are the complications, and GI tract are the most common poor health indicators in scleroderma. So function's important and all these other things, but they're a big deal, probably because they're so common in so many of the patients with scleroderma. So Raynaud's and ulcers on your hands or elsewhere, ulcers from calcinosis breaking open, ulcers because there's poor blood flow, ulcers because your contractures, you're hitting on your knuckles a lot. Tight skin can certainly cause pain, and puffy fingers sometimes are painful and sometimes aren't. So why do my fingers hurt? There's a whole bunch of reasons. So we'll talk first very briefly about Raynaud's. So Raynaud's is really common in scleroderma. So in our Canadian group, more than 95% of people with scleroderma, of the 1,000 or so we've looked at, have Raynaud's. If you go to a really warm country, such as, say, Spain, Raynaud's might be 90% of scleroderma. So it's even more common in scleroderma in colder regions. And then in the general population, 1 to 3% have Raynaud's. And often if you have scleroderma, you might have a first-degree relative, your kid, your sibling, your sister, that has Raynaud's, but that doesn't mean they'll get scleroderma, because that's always a fear. You say, I started with Raynaud's and now I have scleroderma. My sister or my kid has Raynaud's. Are they going to get scleroderma? So first-degree relatives of scleroderma patients often have Raynaud's about 10%. So it's higher than the general population. Anyway, Raynaud's are your hands going white and then blue or red in the cold, and sometimes you have quite well demarcated whiteness, pallor, like the color of a white sheet. But sometimes over the years, your Raynaud's isn't as distinct and you're always kind of different colors. So it can kind of vary over time. So the treatment in a nutshell is stop smoking if you're a smoker, avoid the cold. So I can write a prescription for you to go south, but I don't think the OHIP government would pay for it. But avoid the cold. So Always mitts are better than gloves. A hat, because we lose 10 to 20% of the heat from our heads, so a hat. For the younger people, please do up your coats. I know it might not be cool, but it's not cool to be cool either. So our main treatment is calcium channel blockers, which we'll talk about, but there's a whole bunch of other drugs, and if you don't recognize the class, you might be on some of these within these other classes that are out there. So I'm not going to go through all of it. But another question patients ask is, what can I expect from my Raynaud's treatment? So I'm prescribing a med for you, and the answer is not necessarily a lot. So I have to give you an expectation, or you don't know if it's going to work or not. So for calcium channel blockers, when we look within scleroderma patients, we can get a clinically relevant, on average, 1/3 reduction in frequency of attacks. So if you have 20 attacks a week, you might go down to 15 or 12 or 16. So on average, a 1/3 reduction in frequency of attacks. The severity and duration of attacks, so on calcium channel blockers, at least in the doses studied, is unchanged. So less attacks, but they might feel the very same, but at least less of them. And you should get benefit within a couple weeks. So if you're on medicine to treat your Raynaud's, like nifedipine, that's Adalat, those sorts of drugs, if you're not 30% less attacks in 2 weeks, it isn't working. So if you tolerate it, maybe we'll up the dose, and if you don't tolerate it, maybe we'll switch to another one in that class or to something else. And side effects are common: lightheaded, flushing, puffy ankles, things like that. So we did do a meta-analysis, and just to know that the trials are really small, because often scleroderma trials weren't being done in this area for Raynaud's in scleroderma. They were Raynaud's including patients with scleroderma. So you can see we only have a total of 59 patients. That gives us our data in trials, but we have thousands, hundreds of thousands of experience of Raynaud's treatment within all our practices, throughout the world over the last many years. So a 1/3 reduction in attacks. Severity of attacks, no change, it seems, at least on this drug at this dose on average. So on nifedipine's the best studied. So there are emerging treatments. So many of you have been offered probably sildenafil or tadalafil, or we've tried topical nitrates. So sildenafil is Viagra, or for those with pulmonary arterial hypertension, it's also called Revatio. So there are trials now coming out that are showing it does decrease the number of attacks, the quality of life improves, hand function can improve, and there's a trend, although just exploratory, that it might also heal digital ulcers. So we have some data there. There's a new topical nitrate that's not yet out in Canada that is less apt to give you headaches, because high-dose nitrates can give headaches and hypotension, but it's not out yet. But we have the good old nitro tube that you can try to find. It's hard to get, or you can get a patch, stick a pin in it, and put a bit on your fingers and your web spaces to help the worst fingers. So there's some little tricks we can do in that area. If we gave you an oral nitrate or a high-dose nitro patch, we'd probably make your blood pressure go down and give you headaches, and you might say, well, my fingers are warmer, but I can't function because my blood pressure's in my boots. So we have to always trade off benefit with side effects. Other treatments, there's one study of looking at fluoxetine. So that is the serotonin reuptake inhibitors are basically medications used in depression. They're also used in chronic pain, and one of them certainly seemed to be effective in a clinical trial in Raynaud's. An angio-2 drug, or it's sort of like an ACE inhibitor's cousin, might be effective. So there's some things out there. And then we often move on to higher grade or sometimes unproven treatments. So sometimes, some of you in the room years ago might have gotten a sympathectomy or sympathetic blocks, because sympathetic nerves are all over your blood vessels. Your blood vessels are inappropriately contracting all the time. They're also of a fixed narrowing, but they're in spasm. And if you cut somewhere the sympathetic nerves, instead of tight spasm, they might not be open as much, but they're still open like as much as normal, but they're still opened a bit. We don't do that so much now, because I think we've learned to use the traditional drugs better, and because we do use a lot of these PDE5 inhibitors, these Viagra kind of drugs. Steroids don't work. There's a treatment, unrandomized study, so non-randomized, the Botox injections to, again, kind of paralyze probably the nerves where the digital arteries are. I don't have experience really too much with Botox injections, but there's some case reports in a case series. If someone has really bad Raynaud's and gets digital ulcers, I usually put them on aspirin. I feel better. I don't know if it helps you, but I think it's a good thing. So we don't have trials with aspirin, but we do know that when you have poor blood flow with digital ulcers and your arteries are kind of either damaged and almost gone, or in spasm all the time, that you don't get very good flow. So we don't want little microclots there. So aspirin, if you have digital ulcers, makes sense. But if you said, is there proven data? No, but many of us do it. And then maybe biofeedback. If we move on to complementary and alternative medicine, we've done a meta-analysis, one of my trainees, of all the randomized trials out there. And in general, most things didn't work. Sometimes it was poor trial design, so maybe things like biofeedback would work, but in the trials, the sham biofeedback was less often, less visits, so people weren't blinded. They kind of knew what they were on. So it's really hard to tell, but it looked like laser worked slightly, which surprises me because the laser isn't a very strong thing. It's almost like a laser pointer of strength, but it looked like it might work. And not surprisingly, insulated gloves were better than no insulated gloves. So keeping warm, and these were ceramic infiltrated gloves, so it wasn't like your hands were in ceramic. It was something that actually kept, like a Thinsulate, kept your hands really warm. That was positive. And this is just showing you that the benefit is really low. The further away you are from the line in the middle, the better. So the benefit was very low in some of these studies. So we do have guidelines and recommendations. So calcium channel blockers for Raynaud's are usually recommended in symptomatic Raynaud's, and IV iloprost, which I didn't talk about too much, or other prostacyclin drugs would be recommended for severe Raynaud's and certainly for severe digital ulcers. So they're the kinds of treatments you're probably going to be offered in the clinic. Complications of Raynaud's, so you say, why do my fingers hurt? Well, you might have ulcers, so you could have severely poor blood flow, and that would be obviously painful. Anyone with bad Raynaud's knows it can be quite painful. Ulcers on your fingertips or elsewhere. You can have complications like infection, so if you have an ulcer and poor blood flow, sometimes you get an infection in the ulcer or even down in the bone, so osteomyelitis. You might have to have amputations. Your own skin could wither away over time, so an auto amputation or even a surgical amputation. You can have that your fingertip resorbs as you heal, so having pits or tuft resorption. So if you're doing the computer all the time, it's painful to type if you have no padding on your fingertips. So even that, when it's healed, can be painful to you. So for severe poor blood flow or gangrene, use whatever you think you can get your hands on. So I say throw the book at it. So when I get phone calls from other doctors and stuff asking what to do, we have a little algorithm that we tend to go through. That's, we say, you know, maximize calcium channel blockers, add a PDE5, and then I usually would add a prostacyclin or switch depending on blood pressure. And maybe that's when I'd acutely get the pain clinic to do a block. So stellate ganglion blocks are blocking up here for the blood flow to improve on your arms because the sympathetic nerves can be blocked, and you can have a lumbar sympathetic block to block at the back if your toes are really poor, and you can even get a surgical sympathectomy if we're desperate and need it. Most plastic surgeons are not keen on chopping off a fingertip or a part of a finger if it's salvageable. So we really try very hard, and that's obviously anyone with this kind of issue needs pain meds. So I hardly ever offer pain meds to, you know, the regular patient coming in because I try to treat the underlying cause. For something like this, I say, what do you need? You know, you can't sleep at night. Do you need a sleeping pill? Do you need a strong pain med? Because to be a martyr through this is not good for you or your family because it's awful. So some of you are nodding. You know what we're talking about here. So for treatment of digital ulcers, so now I'm talking the fingertip ulcers because of the poor blood flow. So trauma has something to play. Scarring or fibrosis has something to play in that, but not these ones here that are from just knocking your fingers because of your contractures and no skin, not much padding there, and not the calcinosis ones. So for healing of digital ulcers, calcium channel blockers have a little bit of data. Prostacyclins like iloprost, some of the Hamilton group here will receive epoprostenol, that's Flolan for it, and sildenafil. For prevention, bosentan, that you'll hear about a little bit later, has 2 high-quality trials, but it's not approved in Canada, and it doesn't heal ulcers, but it can decrease new ulcers by 30 to 50%. There's one trial of statins, so it was atorvastatin, that's Lipitor in high dose, 40 milligrams, that seemed to prevent new ulcers. So I'm giving most people aspirin because I feel good about it. I often give the cholesterol-lowering drug to decrease new ulcers, even though there's one study. If it's well tolerated, it's probably worth it, and virtually every drug plan will cover that. So those are the types of things we think about, and then beyond that, I make it up. It's eminence-based and not evidence-based. And ulcers occur in half the scleroderma patients, so about 50%. And on any visit coming through the door in any registry in the UK, in the Canadian Scleroderma Registry, in the US Steen Medsker Pittsburgh Registry, 15% of you walking through the door at any visit have a finger ulcer. So they're common, and if you have one, on average you have two. So on average, the mean number of ulcers is about 1.5 to 2, so many people will have multiple ones. And 15% of those 15% walking through the door have complications. So at least one ulcer, 15%, complications, 15%. This says 17 and 16%, but lots of registries are in that same ballpark. And we know that, you don't have to understand this slide, it's just to remind me that hand function is improved when your ulcer improves and is worsened when you have a new ulcer. So we did a little look at this through open label extension of the two Bosentan trials. We wanted to look at people with an ulcer at one time and still with one, without an ulcer, still without one, and then with an ulcer and healing, or no ulcer and one came. So we looked at the 4 cells, and to make a long story short, we can certainly detect to you relevant changes in function if you have a hand ulcer. So they're painful, and not surprisingly, they do indeed limit function. So we have to remember functional impairment, little tricks to help a patient through this, tricks to protect it, and I've learned more tricks from patients than I ever saw in a textbook of how to protect your ulcer when it's bad. And as doctors, we do have to remember pain control. So just to know, I'm not going to go over this in detail, but we do have management algorithms. This is one of many of how to treat your Raynaud's and your complications of ulcers. So often, again, you might have a physician that has no scleroderma patients except for you and your family doc's practice, and you might certainly have a rheumatologist that, if they're not a scleroderma sort of defined expert, that only sees maybe 10, 15, 20 scleroderma patients a year. For our average Canadian rheumatologist that has a great big practice of RA, on average they see 10 scleroderma patients a year. So they know how to get curbside consults for you, but you can also advocate and say, have you emailed somebody or asked them or whatever, or have you looked at, you don't question their knowledge base, but you say, I just went to a lecture and it sounds like there's some new stuff, email Dr. Pope, put her on, you can always use my name in vain. So put me on the hook, because sometimes I think about this every day. Dr. Kaminska thinks about this every day. Not every rheumatologist is thinking about this every day, and general internists are not thinking about it much at all, right? So there's a layer of knowledge and best practice, and we do learn from each other. The same way I'd ask about a rare case and get a curbside consult. I don't see kids every day. If I'm seeing a kid with a disease, I ask the pediatric rheumatologist, give me a curbside. So we do it every day, and don't be ashamed to say or whatever. Just don't confront your doctor, or it doesn't go well. But, on my bucket list of the 2 questions I'm allowed to ask at this visit, one of the questions is, because I had this issue, do you want to just, someone has slides and they're free to give them to you, just ask that way. In a positive way. So the conclusion of Raynaud's, before we move on to some of the other questions, is that basically it's common. It usually needs treatment in scleroderma, whereas idiopathic or primary Raynaud's in the general population often, most of them, the vast majority, would never need drug treatment. Digital ulcers are common, 15% at any visit, and half of you have certainly had them. They're often cyclical, so the only good thing I can say to people is, for really bad Raynaud's or bad digital ulcers, next year could be a better year. They often are like this. So because one year's bad doesn't mean the next year's even worse, and the year after that you want to rip your hair out. It's not like that. It seems to fluctuate for whatever reason. If you have an ulcer, you're apt to get more. So we look at healing. We sometimes look at prevention. And if you've been unfortunate enough to have a surgical amputation, We know the other blood vessels are also really damaged. It's unfortunately a high risk of more amputations down the road because that means end-stage blood flow. So we try to avoid that if we can, but we're aware if one finger really doesn't heal, if you get another digital ulcer, we'll treat it aggressively early, but we'll refer you earlier on too, because there's no point to have pain and suffering if I can't change the outcome to better, like to healing. Okay, so to shift gears, why am I so itchy? So itchiness, pruritus is the medical word for that, was also very rarely talked about in scleroderma until the last 5 years. Patients talked about it, but doctors didn't. They didn't write on it. So we actually have in our Canadian Scleroderma group an itchiness survey, a questionnaire of pruritus. And there's lots of reasons to be itchy. So for the people in the room without scleroderma, if you've had a bad sunburn and your skin starts to peel, the sunburn's really itchy. And as your skin peels, you're really, really itchy. Or if you swelled up for a reason, you retain fluid and your legs swelled and then the swelling's coming down, thank heavens there's treatment. You can be really itchy when skin stretches and improves. So just the fact of the skin changing can be itchy. But within early scleroderma in particular, but sometimes long-standing, we actually have done, for a study I was doing, we did skin biopsies, and we weren't the only ones to report this, but we found there was a lot of mast cells. Mast cells are your allergic cells, so they have histamine granules, so you think of antihistamines. Histamine is an itchy thing. People with antihistamines, the need for antihistamines because of allergies, are sniffly and itchy. So your skin has more mast cells, which makes histamine granules. Within a mast cell, there's sometimes more granules than they should be. So hot tamale skin early on can be quite itchy just from the cells that are there. But inflammation cells and edema, swelling, can also be very itchy. You can also be itchy for a whole different reason unrelated to your skin. So in scleroderma, a few % of you are unlucky enough to have 2 autoimmune diseases. So primary biliary cirrhosis is an autoimmune liver disease that occurs in up to 5% of the limited scleroderma subset, the limited cutaneous, or what you think of as CREST syndrome subset. And the general population is probably more like 1 in 5,000. So in limited cutaneous systemic sclerosis, or the limited subset, some of you will have primary biliary cirrhosis. And the main way that that is picked up in the general population is women, because it's autoimmune disease more common in women, who are itchy. So if I have an itchy patient that doesn't have active skin, I always do an ELK phos, because that's often up in this condition. I might do a bilirubin, and I will do the antibody that is increased in this condition. So some of you are itchy for another reason, and this is something manageable, potentially even treatable, not curable, but treatable. So it's something that we want to figure out. So you can be itchy for lots of reasons. Also, if you have a digital ulcer or your calcinosis, some people's pain heals as itch, and sometimes their pain is perceived as itch. So you're itchy for multiple reasons. Some I can address. So I put people on antihistamines who are really itchy in that active, warm, hot tamale phase where your skin is even pinky red, not just red from Raynaud's, but pinky red. Those people I use antihistamines very, not sparingly, very frequently at decent doses. So if you're itchy, there's lots of reasons, but sometimes we can figure it out and treat it. Okay, so what do I do about the itch? So everybody with scleroderma, I give a mixed message. I say, put your hands in heat or hot water, and that can help them on range of motion. And then I say, if you're really itchy, don't bathe as much. It's like, okay, what do you want me to do, right? So good moisturizer. So I don't care what you use, and if you spend a lot of money and it works, great. I've had people tell me about emu oil, all sorts of stuff. If it works for you and you feel better and you think it's worth it, do it. But we don't have, obviously, proven anything I'm telling you on moisturizers is my own sort of anecdotal and what derms have told me, what patients have told me. So urea containing moisturizers are usually more expensive, but they seem to be better because your skin is the barrier for your body, and in scleroderma, it's abnormal. And even on uninvolved skin, if we did a biopsy, so if you have your hands and your face and neck involved, if I did a little biopsy on your stomach, you can even have slight abnormalities there. Not necessarily clinically relevant, but it's not quite normal skin because it is a systemic illness. But of course, it's way more abnormal if it's clinically relevant there. So less washing, and if you're really itchy, Aveeno and the cheap and easy Aveeno is really oatmeal baths. So half cup of oatmeal if you can get in the tub and do it. Otherwise, you can do soaks in the sink for your hands, and that oatmeal can help itch, just like a kid that you have a kid with poison ivy, that's what we do. Antihistamines. Sometimes we use topical steroids, not often, but sometimes under the right conditions. And you would probably want to consult with your doctor, because especially if you had open areas, you don't want to put steroids in and then get an infection. So there are some things we can do about itch, but I, as I say, learn as much about my patients telling me what that works than me telling them what to do. So if it works, I might pass it on. If it looks like 2 people said it did and 3 people said it didn't, I probably won't pass it on to you. Okay, so you're going to have your keynote lecture on hand function, but I had to put it in as just a slide or two because it's so important to you. You come in and say, why can't I do stuff? They know why you can't, because you know you can't bend right. But your hand function can be poor because your skin is tight, or your skin is quite swollen. You can have tendon contractures, and for patients that have quite claw hands that won't open or close very much, if we did fancy imaging, which we don't need, this is just like from a research perspective, the tendons are almost gone. They have actually scarred right down into the tissues around. So I can do the most aggressive hand therapy in the world, and I'm not going to get your hands moving right, but I want to maintain range of motion, so I fully, strongly believe in range of motion, but I won't get you normal if your tendons are all withered away already. So contractures are really important. There's inflammatory arthritis that's relevant in about 15% of the patients with scleroderma. Lots of joint pain in other people with scleroderma are tendon friction rubs, squeaking, but inflammatory arthritis, 15% of you have that at any sort of like looking cross-sectionally. And the swollen digits, you can't bend right when you have big puffy fingers. So I'm not going to talk much about it, but it's an important question. And sometimes, always prevention's better than treatment. Prevention, maintaining range, better than gaining. But at any phase, I will try to get people functional, if possible, because it's really, really, it's as important as any med I'll give you to have some hand function, I think. So functional impairment is higher than rheumatoid arthritis in most studies, often progresses, unfortunately, so worsening over time. Prevention's key. Treatment, I can treat some of your hand impairment, like the ulcers, inflammatory arthritis, the active skin treatment. I might put you on a medicine to decrease inflammation, a disease-modifying kind of drug. And even small improvement in function might translate to the fact the difference between preparing supper or not. So if we can get you a little bit better, it's worth it. You notice how I haven't said much about surgery here. I rarely send my patients with scleroderma for surgical assessment for hand function, but sometimes I do, and very uncommonly I will. Mostly it's for pincer. You need some kind of grip in here. So if your hands are claw changed and your thumb doesn't work very well at all, to just be able to either grip here or here can make a huge difference. But not routine to send you to surgery. Poor healing, the tendons are withered, lots of reasons why I wouldn't send you. Okay, lots of people will ask, why am I short of breath? And by the way, a lot of you won't ask, and I'll say, why are you short of breath? Or why aren't you telling me you're short of breath? So you undercall shortness of breath. And basically, you could be short of breath for many reasons. So a lot of times you get a chronic disease, it hits you, it blindsides you, and you become deconditioned. So I have patients that were going to the gym. They're so fatigued, they stopped going to the gym, and now they say it's an effort to do stuff because of my disease, but I'm also, my heart rate's up at rest because I'm deconditioned. So deconditioning is common in the general population, but really common when you have a disease that affects your musculoskeletal system. Many of my patients early on that are rapidly progressive and have a tight chest wall are short of breath because it's like breathing with a hard girdle on your lungs. You can't breathe because you can't expand your chest wall. That is not in the majority of you, but patients like that I will give deep breathing exercises to and try to really get everything, try to soften them up as best as I can with the meds we might have. But you certainly might have involvement of your lungs, your pulmonary arteries, your heart, your chest wall muscles, and your diaphragm muscles. So if you're short-winded, there's an awful lot of things that we have to think about. And sort of, you don't always know, but in our sort of mental list, checklist, we're going through heart, pulmonary arteries, interstitial lung disease. We're kind of going through that in our minds as we're kind of looking at what could be going on. So just to know, I didn't want to give too much on treatment because Dr. Kaminska gave you a great update there. But this is shortness of breath. So dyspnea is shortness of breath. So transitional dyspnea index in lay language means change in shortness of breath. And this is from the cyclophosphamide study for interstitial lung disease. And the upper quadrant where the red is, let's see if I can click without changing it. We won't worry about clicking. Sorry. Oops. Sorry about that. I'll have you put me back in. Okay. I won't do it. But the upper, your upper right quadrant where the red is, that's an improvement in that scale, and the bottom opposite quadrant is a worsening. So on cyclophosphamide, most people stayed the same as did the yellow, which was the placebo for the interstitial lung disease trial that was done in the U.S. But you can see more people on cyclophosphamide got that to that upper red, and more people on placebo got to the lower yellow because placebo is yellow. So improvement is higher numbers going up, and worsening is minus numbers. So you can see if you put those two curves on top of each other for the math people in the room, you can see that what you've done is shifted a bell curve to the better, to the right on treatment. More people were the same, but some people improved more so, and you worsened a little bit more on placebo. So if you're short of breath because of interstitial lung disease, and I think it's clinically relevant and I think it might be amenable to treatment, this is now a proven option. And there's 2 randomized controlled trials and lots of years of anecdotal experience that tells you might get some benefit. But the benefit is modest to many people or mild, but you can still, it's a proven treatment. And we surveyed about 100 experts in scleroderma. So a summer student did this, and we said, what do you use for interstitial lung disease? We also surveyed them on who would you treat, and we couldn't get very good consensus. There was great consensus is if everything was worsening, bad high-resolution CT scan of pulmonary fibrosis, so scarring on the lungs, and bad pulmonary function tests, and a patient who's short of breath or worsening shortness of breath. We all agreed on that. That's easy. We got very little agreement in the middle where we said patients not short of breath, but pulmonary function's worsening and it's less than, say, 75% predicted of your volumes and things. So we don't know who to treat. We know who to treat if you're at one end, and we know who not to treat if you have no shortness of breath and no findings, or very, very limited findings. But the people in the middle that are treated and the people at the severe end that are treated, 65% of the experts said they'd use IV cyclophosphamide, and they said they'd occasionally use oral. Sometimes we can't get good access, so we use oral. One trial was IV, one was oral. And then for maintenance, we have no randomized trials, but we know after using cyclophosphamide, the average scleroderma person that got cyclophosphamide, so it's group means, the average, within 18 months to 24 months after stopping cyclophosphamide, was back to how the placebo group looked. So cyclophosphamide can give benefit, but when we stop it, you'll eventually regress again. The disease will progress, in other words, again, on average. Not everyone, but on average. So we just make up maintenance therapy. So people said still IV cyclophosphamide less often, or azathioprine, or mycophenolate mofetil, or who knows. So that's what we said. So we don't really know how to treat you, but at least there's an algorithm that we're submitting to sort of help other people. We'll submit it to the literature to help other docs that don't think about this all the time have at least where we agree and where we don't agree as experts. Then to shift gears on shortness of breath, if you have pulmonary arterial hypertension, we have to have a high index of suspicion. This is just saying, this is in the UK, but the coverage for drugs in the UK is kind of similar to Canada. So the lowest, the blue line, was when there was just one drug available on the market, the IV, continuous IV, epoprostenol or Flolan, and that was the survival. Then within the next 5 years, Bosentan came out, and the green line was the survival. So only in a very brief period of time, survival improved, but it's not a flat line of staying without any deaths, right? There's still mortality with pulmonary arterial hypertension. Then the fainter line at the very top is then the next 5 years after that, where there's now goal-directed therapy. We have all these therapies, and if we target a patient and you don't meet the target, if you have not improved by 3 to 6 months, or whatever your target's going to be on our treatments, our endothelin receptor blockers like Bosentan, our Viagra kind of drugs called Ravadio or Tadalafil, If you haven't improved on those drugs, then mostly we use combinations and we change your treatment. So if you look at goal-directed therapy, the survival's improved again. If I were to show you a slide of lung cancer, all of you know lung cancer is a lot more common than a complication of scleroderma that affects about 10% of scleroderma gets pulmonary arterial hypertension of class 3 or more. So a rare disease with a common enough or rare enough complication. If you looked at the survival of lung cancer over 10 years, you'd never see that. So there's something to be said that if there's a rare disease and treatment is found, even though it's really expensive, it begets more research, which begets better survival. So this has been an absolutely huge breakthrough over the last decade. It's still a miserable disease. It still might kill you. Half the people are still alive at 5 years. It used to be half the people were already deceased at 18 months. So we have a ways to go beyond this, but goal-directed therapy has made a big difference. So if you're short of breath because of that, even if you're not short of breath when we screen your echo, we will move on to more confirmatory tests like a right heart catheterization if we think you might have this complication, because treating earlier gives better results as well, and goal-directed therapy gives better results. Okay, we're going to shift gears for the last few minutes on your gut. So everyone with scleroderma, when I say everyone, there's nothing's ever everyone, but I will say everyone. Virtually, or everyone, with scleroderma has gut involvement. So even if you tell me I don't have acid reflux and or I don't have food sticking, if I were to do fancy tests, you all have differences in your gut. You all do. So in your esophagus in particular. And if you can't swallow, that's really distressing. So anybody in the room without scleroderma who's ever choked on their food knows how awful that is, the feeling of impending doom. If you have scleroderma and every meal you eat, you have that feeling or you're dreading eating, it's not a good way to live. So we try to be very aggressive in the GI tract if we can. Also, if your swallowing tube doesn't contract right, your stomach might also be a bag that it should be an organ, a muscle that contracts, might not contract right as well. So you feel full early. You feel like you ate 2 bites and your meal is done because you feel full. Because chances are yesterday's meal is still in your stomach. I hate to say, but it is. If you have food pooling in your gut, sitting there for a long time because the contraction's off, and I give you something to neutralize acid, because many with acid reflux are on a proton pump inhibitor, which is really good at turning off acid. If we turn off acid, we don't kill bacteria. And if we have a source for bacteria to grow, because you always have a pool of food in your stomach, you often get small bowel overgrowth. And small bowel overgrowth is feeling full early, bloating, sometimes explosive diarrhea, sometimes constipation, and then incontinence of loose stool around it. And you go, what's with that? Sometimes foul-smelling bowel movements, not always. We can treat that with antibiotics. And we don't do fancy diagnoses. We do a history and say, try antibiotics and see if it works. So just if you have these symptoms, there are treatments out there, and rheumatologists aren't as good as gastroenterologists, but we've learned from them, so we've become better. Then really from top to bottom, so dry mouth, discoordinated swallowing at the top, food sticking and discoordinated swallowing, especially at the bottom of your swallowing tube. The swallowing tube or your esophagus is inappropriately open, so acid coming up. A bag in a stomach that doesn't contract right, so food hanging around, feeling full early. Small bowel, too much bacteria growing. Large bowel, less contractions. Could be constipation and bloating down there. And you can have rectal and anus involved, so incontinence happening there. So the whole top to bottom can be involved. So our treatment is where we think it's coming from. We treat. And we treat a lot on, as I say, history. I don't need fancy tests. Like I send no one for a swallowing study, and I send no one for manometry. Sometimes their GI people do, but I can tell you it's abnormal, so why would I send you, right? I need to treat you. I don't need to investigate you. I need to treat you. I may be pragmatic. Some people might send you for tests, but just get on with treatment. So there's lots of stuff we can do that's important to know. And in the GI tract, that's just the side view of a chest x-ray, or a bit rotated. You can see the bottom on the top, the bottom of the swallowing tube is really dilated. That to a radiologist equals scleroderma till proven otherwise, because it's not contracting and it stretches over time. You can still get narrowing dilatation, but it's just not a nice coordinated muscle anymore. And then this is looking down, seeing the red stuff on the lower scope. There is erosive esophagitis, so irritation right before your sphincter of your swallowing tube, which in scleroderma is inappropriately open, probably because of scarring. And that's just showing no contractions on the top and normal contractions of a swallowing tube study on the bottom. So those normal waves of contractions are gone. And then in the GI tract, we have to kind of know if you have low blood, do you have this lower picture of watermelon stomach where it's basically blood vessels. If I have blood vessels and put food in there all the time and even a little bit of acid or just damage from food hitting it, you can really bleed. And you need to be lasered repeatedly if you have a watermelon stomach till it's gone. And you might need lasering again 4 or 5 years from now. But one set of laser won't do it. So if you have a GI doctor that's not used to this, I just say go back. Tell them you need more. Tell them to ask me. Blame me. So we have experts, again, have given an algorithm that we've submitted for publication on what to do. And just the only thing in the algorithm that's important to you is often we use industrial doses of proton pump inhibitors. So your Nexium, Prevacid, Pantaloc, Periat, Lansoprazole kind of drugs. 54% of the experts said they frequently use more than the recommended dose. So more might be better than less if you still have reflux. Okay, what about my sore joints? Inflammatory arthritis, 15%. And in the sore joints, if there's inflammatory arthritis, we borrow from RA and lupus treatment of joints. That's what the experts said. We use the drugs that we use for other inflammatory arthritis. So on that note of the why am I, how can you help me, I hope I've given some of you tools for even perhaps discussing with your physicians in your care, your healthcare providers, these areas so that you can kind of get a sense of, you know, I'm not alone here, but there might be some help in these various areas. So I will certainly stop there. Thank you.